Good afternoon, everyone. Thank you for joining us for Echo Teaching for today. It's the old classic aortic stenosis. We've obviously talked about this before, we've gone through cases, and so I'm going to, instead of trying to go over every little nuance and stuff, let's just try and just focus on the pearls and the pitfalls. And so it won't be an exhaustive thing on how to do it, but more of just trying to pick up those little things that we can do wrong that we've got to try and do better with. I should also say that for those doing the DDU, there will be a question on valvular disease in the exam. There are only 4 valves. 2 of them we don't really sort of do too much about it. I just, but so it's going to be on the aortic or the mitral valve. So you've got a 1 in 4 chance. So worth knowing about these things. And this is a favorite. I think we've had some people who may have done the exam last year, and absolutely this came up last year as someone who did the exam on short term. Okay, so aortic valve stenosis, it is common, because of course so 3% of patients over 75 have it. If you've got a bicuspid aortic valve, you're not, 1 in 50 of people have that. So it's pretty common to have some form of aortic abnormality. All right. Natural history, if you're asymptomatic stenosis, again, even significant, your mortality is quite low. As you start to get symptoms, it goes up and up and up. So one of the things we have to be very careful of when we're looking at it is to take in clinical context into how we're assessing someone. Before we actually start talking about the valve, let's again just have a think of when we're starting to scan a patient, when we look at that first view, the parasternal long axis view, we've got to have an idea that if we're seeing a valve that's we think it's thickened up, particularly if we haven't got great images, one of the things that you've got to have a look at is to have an idea that if we think that there's something that's causing chronic obstruction, is to have a look at the entire heart, right? So if someone's got long-standing chronic stenosis, you're expecting to see some form of compensatory changes, and that will be in the form of hypertrophy. I don't know if any of you had the chance to look at, if any of you had a chance to have a look at Faraz Pathan. I've called it reporting with the legends, and we went through a case of aortic stenosis with Faraz, and I put it on our website, but I learned a couple of really important things in there. But one of my favorite comments from Faraz in that was him saying that the parasternal long axis view was a really good view to try and tell you things that can kill a patient, and it's also the view that embarrasses people reporting echoes. And I thought that was quite a good example where I, for example, have thought that someone might have had severe aortic stenosis, but they had perfectly normal sort of myocardium, and so that doesn't really go together. If you think you've got significant stenosis, you're going to have some form of hypertrophy.
What happens if they have cardiomyopathy secondary to the stenosis?
Yeah, absolutely. Excuse me, of course. I guess that's somewhere with a normal ejection fraction. Fair comment. So if you've got some form of long-standing ischemia, of course, you can get some form of thinned myocardium. Absolutely. So that would be the caveat to that comment. Excuse me. I use this saying a little bit, and I think it works really well with the aortic valve, is if you've got that valve that is causing chronic obstruction, you're going to be getting these changes, including the hypertrophy. But of course, you see other changes, and this kind of goes for any kind of valve disease, I think, is that you've got to look sort of behind the flow. So you'd be expecting to see changes if you've got significant stenosis. You expect to see some form of hypertrophy. You expect to see raised left atrial pressures and diastolic dysfunction. You will eventually see systolic dysfunction. With the raised left atrial pressure, the left atrium will dilate. That will cause buildup of pressure behind it. You'll see on the right side of the heart with pulmonary hypertension particularly. And if it's really bad, maybe the RV function goes down. Maybe you'll see other lesions affected. If you've got that degenerative aortic valve changes, you might see that with the mitral valve, mitral annular calcification or mitral valve thickening, particularly in those people with chronic renal failure or those patients on dialysis, for example. So I use the expression, you've got to see the whole heart. Don't get focused in just on that one thing, and you've got to take everything into account. And as I said, it's really important to take in the clinical symptoms with that. If someone's got severe aortic stenosis and they're asymptomatic, you can't just ignore that, obviously. And even more so if they're got severe aortic stenosis and they've got clinical symptoms of syncope, shortness of breath, reduced exercise tolerance, difficulty getting off a ventilator, you know, that's a different ball game. I think that puts the level of anxiety you've got to be feeling when you're looking after these patients higher. So again, just looking at the whole heart together, which is why it's so important to do a comprehensive study, have a systematic way that you analyze the heart so that you don't miss stuff. So in the exam, if someone asks you, how do you assess aortic stenosis? This is a way of doing it. This is the way I do it. And I do it so I don't miss out things. You know, it's good to have a framework. And when we're talking about valvular analysis, I start with my 2D. I can think about maybe M mode in there if it's important. I don't think it's super important with aortic stenosis, but might be with other valves, I guess. But I start with my 2D. I think about color Doppler changes, pulse wave Doppler, and continuous wave Doppler. And if you're doing something like systolic function, tell me how you analyze systolic function in the LV, for example. You'd say 2D, you could think of, maybe that's not color Doppler now, but you have 2D, you'd have pulse wave Doppler things, you'd have continuous wave Doppler things, and tissue Doppler. So just try and split it up when you're trying to discuss how to assess things with echo. So let's start with the 2D features first of all. So the aortic valve obviously has 3 cusps. They're normally thin and open beautifully like a flower. Normally got a valve area about 3 meters per second, and the flower should open up nicely so that you see a nice hole approximately 3 centimeters squared in size. Hatton, can I ask you a question? So can you see the aortic valve I've got there? So can you tell me, is that a TTE or a TOE image?
This TTE image, a toe image.
Very nice, because we've got that wibbly bit up the top.
Septum.
Fantastic, it's the intraatrial septum. So that cusp is going to be which?
So that would be the right coronary cusp.
Sorry, I'm pointing at the one next door to the intraatrial septum.
So that would be the non-coronary cusp.
Very nice. So that one will be the...
That would be the right.
Fantastic, because it's next door to the right ventricle, and
the
that means
right
the one on the left is the one that's left is
and
the...
that would be the left coronary cusp.
Yeah, beautiful.
And if you go up, you may be able to see the ostium for the left main.
Yeah, fantastic. So you get the ostium for the left main, it should be coming off. You may be able to just see it in there, and then somewhere in there on the right one, it's somewhere around about there for the right coronary cusp. So yeah, I always start at the intraatrial septum. Next door to that's the non-coronary, and then the right one's next to the right and the left's next to the left. Okay, so 2D. First thing we do is we just look at it, right? So comparing that picture that I just showed to the one that we've got here, you can see that, first of all, the leaflet edges they look brightened and they look thick. So bright, thick, that means some form of something like calcium. It's probably the most common thing to block up the valve, right? And it affects the edge of the aortic valve. So we're getting some form of aortic valve sclerosis, I guess we could say, or aortic valve calcification. Pretty common degenerative changes. You can see the opening is not as big as the on the last one, the normal one. And so we might be able to start thinking, oh, there might be some kind of obstruction that's going on with this one. We can do something called aortic valve planimetry. So you wait to see when that valve is opened up as much as it can. And then you can see with this measurement I've done down here, I've measured it here, and I've got a planimetry value of 1.5 centimeters squared. So this may suggest that we're sitting in the, say, moderate, so normally cutoff's about 1.5, between mild to moderate. So we can say this might be in the moderate severity category. So who's next? Joe. Joe, am I allowed to ask you a question? Or is your video off, means I can't ask you a question?
Oh, no, you can ask, yeah.
Thank you. So first of all, same as to Hatton. So this view up here, is that a TTE or a TOE image?
A TTE.
TTE image, because the bright line down there is the interatrial septum, and then you got the tricuspid valve up there. So TTE, beautiful. So that means that is the non-coronary, right coronary cusp, left coronary cusp. Beautiful. So I've measured this at moderate aortic valve severity. What is wrong with this? What is wrong with that statement, I guess? Because I've measured it all up. It's saying it here nicely. The computer's telling me it's moderate. I listen to Sam's lectures. He tells me 1.5 is moderate. Why can we not trust that?
Because you're only measuring one aspect of it. You don't know what the flow is through the valve and the pressure gradient between the atria and the ventricle. So that can affect how wide the valve opens.
Very nice, very nice. Take it back a step, because I think those, yeah, so let's
I mean, the aorta in the ventricle.
Yeah, so if you imagine my hands are the aortic valve, right? We need to know where the smallest opening is. And that's where we should be making the measurement. And one of the problems with this is obviously, again, we've got a 2-dimensional imaging tool, 3-dimensional structure. You don't know where you're cutting that aortic valve. So you've got to trust and you've got to know that you are imaging it exactly perpendicular in exactly the right area. And the next thing to say is, as I'm sure you guys have tried to do this, is it's not that straightforward. Particularly, it looks like it's easy when the 2D picture's moving, but then suddenly when you pause it and you're scrolling through it, you're like, actually, I have no idea where that valve is. You can see I've sort of gone up into this edge up here. I don't really know if that's right or not. You know, you've probably got a bit of drop out here. Is it sort of there? I don't know. It's particularly when you've got, I find it with TTE images, particularly when it's a little bit of a rubbish picture, particularly when the valve's calcified, it's just got a massive fudge factor in it. So my personal thoughts is that I don't do it regularly on the TTE image. I think this image that I took here is a bit rubbish. I don't trust the value. On TOE, it might be a little bit better. But again, you've just got to be really careful. You've sort of scanned through the whole part of the aortic valve and you're trying to pick it up right at the top of the leaflet tips. And so imaging is essential. So this is one of the values that I think is least reliable. I'll do it in TOE though. If it doesn't match up with other more reliable things, I'll probably ignore it. Okay.
Hey Sam, it's Jamal here.
Hi, Jamal.
Hey, just a quick question. I mean, because I see a lot of intra-op aortic stenosis aortic valve replacements. What's your kind of understanding or appreciation of the change to the AHA?
Well, we lost you that bit there, buddy. Oh, Jamal, I'm sorry, I lost you. You still there? Always makes me nervous when you get consultant anaesthetists who know what they're talking about asking questions anyway. That's probably very good. We'll bring him back in a sec. I'll just carry on until Jamal comes back in. Very quickly on congenital.
Hello?
Oh, hi, you still there?
Yeah, sorry, I think I froze either before or after asking that question.
That was right. Just tell me, we got to the change in the.
Yeah, sorry. I'm just going to move where my signals are better.
That's right.
The change to the AHA, ACC guidelines, where they've kind of removed valve area from mild or moderate aortic stenosis, and this kind of new A, B, C, D severity of aortic stenosis.
I mean, I'm still working off the valve area, I got to say, because I think it's probably the one that's most commonly recognized still. So it's not, and I think the change in nomenclature is great, but it's still, I don't know, I still find that it's quite useful, really. Yeah. What do you say, in terms of the surgical world, they're moving towards that, are they?
Very much. Well, I mean, because when you say the quote unquote new valve severity guidelines, these are from 2013, and a lot of the cardiac thoracic literature and discussions, and especially cardiology discussions, have moved into kind of categorizing aortic stenosis in this kind of A, B, C, and then D1, D2, D3.
That's fantastic. I mean, that's not something that I'm doing routinely. I'm still sticking with the aortic valve area, and that's sort of
that's what we've been doing, but as you say, it's kind of, you know, it's the new guidelines from 2013. There's a recent December 2020 kind of clinical update, and again, all the aortic stenosis discussion from AHA ACC is A, B, C, and D. And as you say, you know, the valve area has only ever been a class 2 recommendation for all the reasons you've discussed. And now for mild or moderate, they've removed the necessity for a valve area.
Yeah.
But they're keeping velocity and gradients. Anyway, I think we are in this kind of middle ground of people not quite have made the move to the A, B, C, D nomenclature.
And I wonder from a critical care point of view, whether, I think obviously we should know about that, but I also think, we're probably not the ones who are going to be deciding whether someone needs a valve replacement. And maybe that's where the symptoms come in with the alphabetical grading system. It's not just about the valve area, I guess it's considering the symptoms.
Sure. Well, yeah, but the ABCD criteria has, definition, valve anatomy, valve hemodynamic consequences, and symptoms.
Yeah, exactly. That's what I mean. Yeah.
Part.
Yeah, nice. I think it's a really good comment. I'm sorry, I have not included those up-to-date guidelines in this, and just. But that's a great thing that we should talk about again at some stage. Nice, thank you. I put this slide in mainly because I wanted to put the quadricuspid valve in, because that's a really rare one, and I got this stunning view. This is a 20-year-old kid who came in because he was having an overdose, and he got a transthoracic echo because he was on a not unreasonable amount of noradrenaline, and we had slightly tricky views, and the valve did not look right, and so we ended up doing a tow on him because the valve was unusual, and we thought it was going to be bicuspid. It comes out this beautiful quadricuspid valve. And I try and show this picture whenever I possibly can because it's so beautiful. And he was completely fine and came off his inotropes, no problem at all. But so the quadricuspid is super rare. If you get a picture, I encourage you to show it whenever you can. What is very common is the bicuspid valve that you can see at the top there, and the left and the right raphe being joined is quite a common one that you see. And just remember, if you're seeing someone or anyone with a congenital valve abnormality, you must consider there being aortopathies associated with it. So as I said, the bicuspid valve, pretty common, particularly fusion of two cusps along the raphe, we call it. Often completely asymptomatic, but can be associated with valvular stenosis and valvular regurg. And you've got to be careful with the stenosis because you can often have a valve that opens up beautifully, but you still get quite high gradients. And that's because you're often going through the edge of the valve. So I sometimes find they're quite tricky to analyze these guys, and you've got to try and make sure you're fanning through that with your continuous wave Doppler. So don't forget, as I said, the aortopathies that are in there with the aortic valve abnormalities, the congenital valve abnormalities, and you can get dilations anywhere along there, and including coarctation, and if something goes wrong, a dissection. Okay, so back to sort of the more standard stuff on the 2D. This is what a sort of common elderly patient with degenerative changes of the aortic valve is going to look like. So you get this kind of raggedy, bright valve that doesn't open properly. Normal valve opens up nicely, craggy valve staying closed, just little bits of opening, and this could be in keeping with significant aortic stenosis. Okay. You'll notice that we've got a big hypertrophy that's here associated with it as well. Take note that maybe the ejection fraction looks okay in this view. Maybe we're dealing with a small stroke volume potentially, so normal ejection fraction, maybe small stroke volume, worth keeping in mind as we will get towards the end. And other valves being blocked up as well. Decent sized left atrium. All of this stuff's going through my mind saying, yeah, this could be significant aortic stenosis. Make sure I get my imaging of Doppler, has to be correct. So don't mess around with this case. Take my time, look at it in lots and lots of different angles. Color Doppler, we're going to put color Doppler over it, and in the parasternal long axis view, we're looking for this chaotic motion. So I probably could have made this box a little bit higher into the ascending aorta, but you get the idea here that we're dealing with lots of chaotic motion that's coming in. And again, that would point to, I think we might have some significant stenosis that's going on here. The benchmark that we're going to be able to try and aim for is going to be the continuity equation. Again, I'm not going to go through too much of this with this group. There are other lectures that we recorded that can go through this in a little bit more detail, but as I'm sure you're aware, we need to have a look at what the valve area is, and we do that through the continuity equation, where we say that the sort of volume of blood that's going through here, which we define as being the LVOT area times by the VTI, or the velocity time integral, or how long it takes that block of blood to move forward. And then we can times those two together, and we can compare it to this area up in the top of the aortic valve, where you'll have a smaller area that we don't know, but we do know what that VTI is, and then we can compare the two. So we can say that the area of the aortic valve stenosis is equal to the LVOT area times the VTI divided by the VTI of the aortic valve. Okay, I'm sure you guys know that. You are expected to be able to rattle that out in the exam. You're expected to be able to calculate it in the exam. And if we're not allowed to, you're not allowed to take in calculators, so we'll obviously make the maths pretty simple if you're going to do that. But you are expected to be able to know and do that. So there are problems with that, okay? And that's what I kind of want to sort of, what I want to jump on. So to do that means you've got to have accurate measurements, right? And the first accurate measurement that we've got to do is got to get the LVOT diameter accurate. Because if you get that wrong, you're going to square it, right? So any abnormality that you make with the LVOT diameter, you've got to make sure that you know that that's where an error can come in, and that can cause either overestimation or underestimation of the valve severity, all right? So the place you're meant to do it is at either the insertion of the leaflets into the LVOT in the anterior mitral valve, at the insertion point there, and the ASC guidelines actually say within about 5 millimeters of there. So somewhere around there, you make that measurement, and then you do I do 0.785 times the diameter squared, or you do 3.12 times the radius squared, whichever one you want. And that will give you that area there, okay? The VTI is measured in the apical 5-chamber view, and we'll talk a little bit about accuracy about that in a second, and that's with pulsed wave Doppler. And then the continuous wave Doppler, you get the aortic valve, all right? And that's going to look for the highest gradient along that line. And again, just don't forget you can get problems with that too, which we'll go through. So with the Doppler, again, I've said this many, many times, just you've got to use multiple angles. A single Doppler trace is not enough when you're looking at someone with this kind of picture that I showed earlier with the potentially significant aortic stenosis. We've got to have a look at it in multiple gentle movements in the apical 5-chamber view. I want to look at it in the apical 3-chamber view. If I've got a sonographer who's got some time, they might be able to help me out with my suprasternal views, my right parasternal views, if they're good with the PEDOF probe. But, someone who's got all those 2D features that we looked at a few slides ago, we need to do this properly. That is not something that you just flick through. Like sometimes we might, if the valve looks fine and it opens well. Sure, we can flick through that, but not when you've got a valve that looks like that. So lots and lots of different angles. Okay, next thing you're expected to know, I don't expect you to know every number in this, but I do expect you to know about those. So again, you could be asked about these. We might put something on the lines of, give me the values of severe aortic stenosis in someone with a normal ejection fraction or something. And so the numbers we should be able to rattle off would be a peak velocity of greater than 4 meters per second, a mean gradient greater than 40, a valve area, maybe less than 1.8 in other guidelines, but somewhere around there, and a velocity ratio or a dimensional severity index, they both call the same thing, of less than 25. Okay, so those are the numbers that we should be able to just smash off. And you'd be expected to know the same things for aortic regurg, mitral stenosis, mitral regurg. Okay. And we'll go through those another time. Okay, so each way that we can measure those severity, about those ones that I just said, the peak velocity, the mean gradient, the valve area, and the dimensional severity index, and the planimetry, I guess we could add in, all of those have advantages and disadvantages. And we'll just very briefly just go through those in order, okay? So, hang on, I want to ask some of you guys. Heyman, can I ask you a question? Is that okay? Your video's off, I don't mind. If you don't want to answer a question, I can shut up.
No.
You good to go? Cool. Okay, so give me an advantage and a disadvantage of the peak velocity gradient, particularly with relevance to the critically ill.
The peak velocity, obviously, as you can see there, it's obviously a direct measurement.
Yep.
The disadvantage is that
Give me another one in the critically ill. What's another good thing about it?
It's the strongest predictor for outcomes.
Yeah, nice.
It's all
I was going to say, it's
also
also easy to do, right? We all know it, and we can do it, and I can get a number pretty easily.
Yeah.
Cool. What about some of the limitations with it?
It's flow dependent.
Yeah, and what do we mean by that? Just explain that to the rest of the group, what we mean by flow dependent.
If for some reason there's a low flow, then the pressures for or ejection fraction is low for say, or there's a LV dysfunction,
Fantastic.
then your peak gradients will be lower.
Yeah, and give me another disadvantage.
The more common one is obviously the fact that we may not be able to line itself properly if we don't get proper velocity parallel. The ultrasound beam is not parallel to the flow. We may not get proper velocities.
And exactly right. So what? And my day-to-day experience of that is when I figure out someone's peak velocity gradient, I then ask one of the sonographers to do it, and they always get higher values than me. Right? That's my general experience, and that's because they're better at imaging than I am. Nice. All right, same thing. Where are we up to? Vijay, do you want to have a go with the mean gradient? So again, give me advantages and disadvantages.
It's almost similar to the peak velocity. So it's again flow dependent and angle dependent.
Yeah.
Again, if the angle variation is too much, you may measure it wrong. Again, if in case of anemia and tachycardia, things can be different versus systolic dysfunction causing low mean gradient too. So
beautiful. And so as well as the Doppler angle, it's also the way that we measure it on the Doppler profile. So when we're measuring on the Doppler profile, I think it's easier to get I guess it's the same for the peak velocity, but also for those mean velocity, it's easy to get them wrong. So what do you have to do on your Doppler profile? Let's say we've got the best angle we can with the Doppler interrogation. What about that Doppler profile? What do you have to do?
So you need to measure on the modular velocity. So basically, you need to avoid, they say, beard and the fuzzy part of the beard. So, so you say you need to measure the modular velocity so you don't take the fuzzy part of the curve.
So how do you get rid of the beard? How do you get rid of the fuzz?
Yep.
How do you do it? How do you get rid of the fuzz?
One, you can, I know it.
Yeah, it's turning down the gain. You just got to turn down the gain.
Yes.
If you turn up the gain, you get all the fuzz that comes in. As you turn it down, that decreases, and you just get left with that modal velocity, as you said. Very nice.
Yeah.
And then you just got to make sure that you trace the outline of the parabolic flow as accurately as possible.
Yes. Yes.
And again, the little tip and trick I have for that, it's a bit like we're doing it with the ejection fraction I talked about a couple of weeks ago or something. Whereas you don't look at your cursor, you look ahead of your cursor. And it's like driving a car. You look past the bonnet and the car kind of follows it. Same thing. You look ahead of where your cursor is and your cursor will follow it nicely.
Yeah.
Sam?
Yes.
The ASE guidelines talk about this pressure recovery thing about changing in potential energy to kinetic energy. Is that a big issue or not?
No, I don't think it is. So it's probably, it won't, I don't know how much I tell you, but the, and this is being recorded, I'll get into trouble with ASEM. We're not going to ask you about that, to be honest. It's not a major deal. I think it's, if you're doing the ASE exams, they love asking about it, pressure recovery. Clinically, I don't think it makes much difference. The areas that it might make a difference in clinically is if you've got someone with paradoxical low flow stenosis in elderly small patients, it might have a difference there, and that's because such small changes can make a bigger difference, and we'll go through that maybe at the end, but it's not clinically, I don't think it makes much of a difference.
Thanks.
Oh, Joe, while you're here, talk to me again. We talk about the continuity equation. So continuity equation, everyone loves doing it. We talk about it. I'm going to make you do it in a minute. What are some of the bad things? We talked about the LVOT and errors being squared. What else?
You need to make sure that for the cross-sectional area, you've got your measurements exactly right of the LVOT, which I suppose is what you've said about the and
it would be the same thing with pulse wave Doppler, right? How do we make sure with the pulse wave Doppler we're in the right place?
You mean in the apical?
Yeah.
So you need to have your cursor aligned with the gradient of flow. So you need to put some colour on to help you show where that main flow, so you get the fastest velocity.
Yeah. Because what we're trying to do is we want to put the cursor in the same place that we measure the area. We want to put our cursor in exactly the same place, right? Yeah. And so how do I do that in my apical 5-chamber view? What's key to the Doppler profile of your LVOT VTI?
You put the put the gate just in front of the aortic valve, so you get the closing click.
Beautiful. So you don't want the opening click, because that means that you're too far in, because you get both the opening and the close. You just want it right at the base so that nothing's opening, but as it closes, you get the click that comes through, and that tells you that you're in exactly the same place that you measured it in the parasternal long axis view where you got it. And the last thing to say is you should zoom in on that parasternal long axis view of the aortic valve, so you make that measurement as accurately as possible. Sweet. The velocity ratio is amazing, I think, because you have to do less measurements, so it's less prone to error, and it's an easy calculation. So, and less than 0.25 is severe, greater than 50 is mild or nothing, and so it's good. It's less flow dependent. Beautiful. And planimetry we already discussed. Yeah.
Sam, quick question. Is there any influence by the sample volume when we gate it?
No, so the sample volume is classically about maybe 8 millimeters. It's the smaller you have your sample volume, I guess the more accurate the blood flow going through there is, but the more prone it can be to error, I guess, from angle. So the classic one, I think that Benita Anderson puts in her article is to say that we should be between, I think it's 5 to 8 millimeters. And I do whatever Benita tells me.
Okay.
As we all should. Okay. Yes.
So you sometimes find when it's really stenotic and thickens that you lose that closing click, and so sometimes it's hard to then know exactly what.
Wow, what an interesting question. So did everyone hear that? So when it's horribly stenotic, do you lose that closing click? I still think we should go hunting for it. And I guess the answer to that is, yeah, you're absolutely right. It can be easy to lose, but it's the only way that you're going to find that you're in the right place.
It's the ULT closing click.
Yeah.
It's so that, yeah, but down below.
If you haven't got it, it means that you're too far away from it, or you're not got the best angle possible.
Yeah.
So I guess use on this one. What do you think of this measurement? Who do you want to go? Emma, do you want to go this? What do you think of this measurement? So we got an LVOT VTI of 31.4.
Oh, wow.
Mm.
Well, I think it's not overgained. Like the gain seems appropriate.
Nice. So the gain seems okay. Yeah, all right.
The scale and the speed time is again appropriate. I think we've got. And there's turbulent flow through there. It's not beautifully, which fits with it being aortic stenosis. I guess we're not seeing that nice.
Well, I don't know if everyone can hear. Just speak up a little bit.
There isn't a closing click.
Yeah, nice. So we don't have a closing click. I think we can talk about maybe we're measuring the fuzz in some areas, but I don't think it's the worst measurement. I've done a lot worse. I think the angle probably looks okay. They've optimized this picture quite well. We've got the baseline towards the top. We've got 3 or 4 cardiac cycles filling the screen. So it's not the worst image in the world, but we don't have that closing click, right? But this I find weird. 31.4. What do you think about 31.4?
It's very high.
It's very high. So what's normal?
Around.
Yeah, so 18 to 22 is normal. So if it's super high, that just makes me think, I've got to be looking for someone who's either got a heart that's, really looking like it's pumping out some blood. So it's either a hyperdynamic ventricle, someone with severe sepsis or a high cardiac output state, but they don't look like their heart rate is super high here. Have they got really low afterload for some reason? So a load of blood is being moved forward. I'd be wanting to know why they've got such a high LVOT VTI.
And also the average.
Or AR, beautiful. Or AR, very nice. Sorry, did someone else say something?
I said we need to look at the average. We need to just take a couple of more measurements and take an average of it.
Absolutely, take an average. But they do look kind of the same size each. Yeah, but very nice. You've got to take an average of 3. Nice. Okay, what do we think of this measurement? Anne-Marie?
And so it's parasternal long axis view.
Parasternal long axis view. Yep.
It's not zoomed enough, and the measurement's not directly vertical. So the error from the resolution, axial resolution is superior to lateral resolution. So you're going to incorporate some error and then square it. So you should try and shift the image so that the LVOT is perfectly vertical.
Nice. So we're trying to make that as vertical as possible. If you can, if you can't, we sometimes have to do the best we can. Nice. And we're measuring here. We can almost see a valve there and sorry guys, I can't point my finger. Valve there and a valve there, and they're sort of being in the base of there. So I actually think this is one of my measurements. So
And the measurement sounds very big.
yeah, nice. It's really big, right? So it's 2.7. So what's normal?
Around 2.
Yeah, around 2, right? So again, if I made this measurement, the next thing I want to go is like, wow, that is massive. This guy better be 6'8" and 125 kilograms and a basketball player, or I've made an error, right? So that'd be the next thing I want to go and do. That's a weird value. Go and check it out. Why? And be very, very cautious if I'm doing my continuity equation that I don't overestimate the size of the valve. Oh, and this is a great one. So this is a tip and trick that I learned from Faraz when I was doing that reporting with the legends thing. It was really cool. If you haven't, I'm going to start trying to do these a bit more, where I'm going to call in amazing cardiologists to come and report some studies with me, because they do have the most amazing little tips and tricks. And this image reminded me of something that Faraz said. So what do we think of this? What do you think of this picture?
Well, this is an image. There's no measurement on it as far as I can
Exactly.
tell. So
We can get quite a lot of information, I think,
Yes.
yes, because I'm going to use this picture to then put my Doppler alignment with.
okay, so there's not much turbulence for forward flow through the valve.
Okay.
There is significant regurgitation, but it's eccentric. So if you wanted to get the regurgitation spectral Doppler, you would need to turn it more on the angle so that you could match the angle. You need to
Get the
turn
angle.
the image more
Nice.
on the angle
Beautiful.
to get a good angle.
Cool. I guess the other things that would flick through my mind is that we've got quite a high scale here. So never forget, if we show you a picture that's got color Doppler in there, always have a look at the scale, right? Because that is going to mean that with that kind of level of 87,
Overestimate the aliasing.
and it would
But
make that look
make the
less as well.
regurgitation.
Look smaller. Fantastic. So that means that regurgitation could be quite a lot. And I stole this picture from the one that we saw before, the LVOT VTI of 32. And that's why they've got an LVOT VTI of 32, is because of this regurg. But the next thing is, and what I learned from Faraz, is do you see how it gets cut off? It looks like we might have some form of chaotic motion there, but I've kind of cut it off. There's the 5-chamber view. You don't have any, Faraz called it bleed. You don't have any color Doppler bleed going into the ascending aorta. And what that might tell you is that, let's say this is the ascending aorta and there's the aortic valve. What this picture might tell me is that I'm cutting it at an angle, right? Because it gets closed off at the top. And that might mean that my Doppler angle, therefore, is not, it might be in alignment in this, the plane that I can see in my picture, but it's not in alignment in 3 dimensions. And so what I took away from Faraz's comments is that when we're looking with color Doppler here, we might want to angle up a little bit more in my 5-chamber view here to try and make the color Doppler bleed look more like a cylinder going up. And that tells me that I'm more in line in 3 dimensions to try and get the best Doppler angle of interrogation possible.
Do you mean that you want the color? You want the color coming down here?
Yeah,
Is that what
exactly,
you mean?
exactly. So it would be in the ascending aorta, something, looking at the color Doppler bleed coming up here. So it's not just about trying to get your Doppler angle perfect in 1 dimension, it's trying to make sure it's perfect in 2. I thought that was a pretty, I thought that was a pretty cool little tip and trick.
And Sam,
Yeah.
with the previous picture as well, it doesn't look like the systolic function is at its best.
Yeah,
Which-
really nice comment. That's
Yeah.
brilliant. Yeah,
Which
completely
potentially
agree.
could be a low flow state.
Yeah.
So
And we'll just come on to that right now, actually. Just in the standard thing, the pearls are, you got to see the whole heart. And just as Hatton said in there, part of that is trying to have an idea of what the ejection fraction is. We got to look at the idea that we've got a complex 3-dimensional structure. We got to look at multiple different angles. We got to know the limitations of every measurement we're making. And if we're using Doppler, make sure the angle is perfect. And that means that we've got the best data possible to make assessments of size of, valves. Okay. In the meaning of time, I might just skip over this, but just be, if you're doing the ASE exams, we've put one like this in the DDU exam before. we might give you a whole bunch of information and ask you to make the equation. So here, if I've given you the peak velocity, the mean gradient, the VTI, the pulse wave Doppler, LVOT velocity, and the VTI and LVOT diameter, what is the estimated aortic valve area? So, oh, go on then. Just why don't you just quickly give it a go? Give everyone 30 seconds. I need a calculator. Oh. What do you get?
0.8 or 0.6.
Sweet.
0.8.
0.8, nice. Anyone have difficulty with that one? So the little trick that I did in there to try and trip everyone up is I put 20 millimeters in there. So just remember, you've got to change, everything's got to be in the same thing. So if your VTI on your machine is given in meters per second, you've got to change it into centimeters. If your measurement is in millimeters, you've got to put it up to centimeters in your LVOT. So yeah, the answer is 3, 0.8. And yeah, just go through it systematically. Okay, let's just in the last couple of minutes just go through particular circumstances that will be asked if you're doing the ASE exams. They love asking about these, okay? Each one is probably a topic unto itself, but I'll just sort of touch on the highlights for each of them. So the one that we love asking about in the critical care DDU is the low output state. As I'm sure you come across, you're going to see people who've got poorly functioning ventricles, either acute or chronically, and they can have significant aortic stenosis. And of course, that means that less blood is going to be pushed out through the aortic valve, which means that all the flow dependent variables, such as the peak velocity and the mean gradients, will be lower. So you can have people with severe aortic stenosis who have peak gradients that are less than 4 and mean gradients that are less than 40, and but they still have severe aortic stenosis. So what does that mean? It means that you've got to do your calculations to try and work out your valve area. Or my favorite one is just using that using the dimensionless severity index. So you just compare the VTI from the LVOT and the VTI from the aortic valve. And if it's less than 25, that points to severe. You've got to have accurate measurements to do that. Okay. So that'll be the first one to get wrong. So.
Sorry, if you've got a low flow state and VTI still suggests it's severe, it could still be pseudo-severe.
Which we're coming on to just now. It could be still pseudo-severe. So pseudo-severe, and that's where I guess you've got to do your continuity equation in there, and you've got to think about, so what could you do to try and figure that out?
You'd have to do a DSE.
You'd have to do a DSE. So you've got to try and think about some ways to increase the cardiac output and see if it changes, because that valve might be ready to open if you put more blood through it, or it just stays, shut if it doesn't, and you don't get an increase in the cardiac output. Okay, so pseudo-severe versus severe. Do you want to have a go trying to explain that for us? Because you just talked about it.
I think of it as like a creaky door. So if you don't push it, if the door's stiff and you're not pushing it very hard, it won't open very far because there's not enough ejection fraction.
Yep.
But then if you push the door harder, the same door will open further. And so what you thought was severe will become moderate, just because there's more force behind it.
Okay, so that's pseudo-severe. Yeah, nice. So you're thinking.
Suggests it's severe initially.
Nice.
Low force, but then it becomes lower.
Let me think about, how about the paradoxical severe? Because I think that could be an example of, I think what you described is not a paradoxical AS. I think that's describing just the need for doing a debutamine stress test in someone with a low flow. I think it's different from this one.
Which
So
is paradoxical. Paradoxical is normal ejection fraction, low stroke volume.
Yeah, nice.
So
So
volume less than 35.
fantastic. So you can have a normal ejection fraction but a low stroke volume, and so that can give you the abnormal. So the low grade, you give you a low grade, but you can still have severe aortic stenosis. Nice. Is everyone good on that? Because again, we've asked that a couple of times. Just make sure you know the difference between low cardiac output states, between pseudo-severe, so low gradient, and the paradoxical aortic stenosis.
They've got the worst outcomes, those ones.
Yeah, exactly right. So these guys often, because they're often these old patients, long-standing hypertrophy, long-standing aortic stenosis with these horrible-looking hearts. What have I got this one for? High cardiac output states. So yeah, the next one I guess that we'd also see quite a lot of would be, for example, this was a patient with severe sepsis. If you've got severe sepsis and a stenotic aortic and a sclerotic aortic valve, so at rest, it might not cause any problems for the patient. When you get to a state of exercise, such as being sick, tachycardic, on inotropes, whatever, suddenly your valve can become functionally stenotic. So that it's not a problem when they're at rest, but when they're sick or when they're running, when they're running, but they probably never run. But when they're sick and they're in a high cardiac output state, suddenly the valve can become very serious. And that might not mean that they're not going to get an urgent aortic valve replacement at that time, but it's worth doing everything you can not to increase their afterload. So these are the guys that I often find are getting calls from anaesthetists about someone who's gone off during a relatively benign procedure, particularly old patients who are having hits done, I find. They do an anaesthetic that's probably fine for the majority of people, but if you've got someone who's got that valve that's just on the edge, and then something goes wrong, such as a tachycardic state or too much afterload for whatever reason, and then suddenly the wheels all fall off, these high cardiac output states can be the ones where they cause problems. I think that's sort of about it, really. I might just start off with this last one. This is a really esoteric one. And particularly this came up when I did the ASE exams. Who's doing the ASE exams other than Emma? Anyone doing them? BJ, are you doing them? Oh, Hatim's doing them. Oh, then we've asked you a question already. Hatim, do you want to have a crack at this one? So I got this wrong in my exam, I think. So I hope you get it right.
I don't feel bad about it. Yeah, no problem.
70-year-old female. She's got a picture that looks like this on a continuous wave Doppler. So she's got syncopal episodes. She's been, and you're doing this echo query, severe aortic stenosis. She's got a good going ejection systolic murmur, and you've got a Doppler profile that looks like this. So what do you think of the Doppler profile, first of all?
So the Doppler profile is terribly bad. So it's well aligned on the 2D image, but the problem that it's having a lot of fuzz, a lot of background. So definitely the gain needs to be much reduced. I can't really see or appreciate the opening and closing clicks. Maybe the opening click, yes, but not much of the closing click. But at least on the 2D image as well, it looks within the valve.
Yeah, and I was just thinking also, I'm getting peak gradients up to 4. With these difficult images, do you reckon we could say this lady might have some severe stenosis?
So this alone can't be determining severity of stenosis. So I need multiple other things to combine it with it. So I need to, yep.
Good answer.
So that's
based on those terrible images and the fact that she had syncope and we thought there were gradients up very much higher, we went ahead and tried to arrange a toe. So what do you think of this? So
the toe is a mid-esophageal view at the angle of 130 degrees. And properly visualizing the aortic valve as well as part of the aortic root. And what I can see that I'm concerned that probably on the left coronary cusp, there could be a potential for some lesion vegetation, some echogenic oscillating mass. Probably there could be a consideration for infective endocarditis. She's got. She's just walked in off the street. She's fine. She's got no infective symptoms at all. So, from the valve perspective itself, the valve is opening properly. But
yeah. So how are we getting a gradient of 4 meters a second then?
I think below the valve there's something that's concerning. So there's something moving around it.
Yeah, nice. Do you know what that might be?
So some sort of subvalvular stenosis.
Fantastic. So, yeah, we call it subaortic membranes. They're not common, but they can come along. And so we can also have a look with color Doppler, and you can see the horribly chaotic flow that we can see with aortic stenosis, but
Yes.
this chaotic flow starts in the LVOT, right? It starts right by where that subaortic membrane is. So this stenosis that we're seeing is not from the aortic
The valve
valve,
itself. Yep.
it's from the subaortic membrane.
Hmm.
Okay, and if you then fan through it, you can see actually that you can imagine it's like
It's
a
much better view.
circle
Yeah.
like that. It's actually a concentric shape that sort of comes up, and that's where the stenosis comes from. And I think as this lady probably became more and more hypertrophied, she's the lady that got that paradoxical severe aortic stenosis, right? It's almost like that, where you get that low stroke volume and the big thickened ventricles. And you can see it in multiple angles here.
Yes.
Now let's say the question that I messed up in the ASC exam, and I can't remember exactly what it was, but it was along the idea of, with this, how do you measure the area of the aortic valve?
So here it will be changing a little bit into what would be the effective orifice area rather than the true valve area. And that would be measuring the gradient at multiple levels and getting the whole continuity equation across the whole gradient. So we'd be able to identify it at multiple levels. And even I can place the pulse wave gate Doppler even below the valve to identify the pressure gradient.
Nice. How would you figure out the area?
It would be better adjusted through the. So here it would be again continuity equation, but be placed across this particular subvalvular area.
Let me flip the question around. Actually, I think I probably asked the question around the wrong way. Let me try again with a different example, if I may, Hatem. So rather than that one, let's say with this one, how would you figure out with this high cardiac output state? Tell me how you would figure out the aortic valve area.
So basically the precise one would be still to have the dimensions index. So that would give a close.
Sorry, let's say you've got to use how would you use it for the continuity equation? I want the exact valve area. So you've got to tell me what the valve area is. You've got to use the continuity equation. How do you do it in this case? Tell me the equation that you'd use.
So you'd still do the CSA, the surface area multiplied by the VTI of LVOT. But on the other example, you'll do it with the VTI at that particular area.
Hang on, someone's going to preliminary. No. What's the key? The key of this is that the LVOT VTI is really high, right?
Yes.
So we've got an LVOT Vmax of 1.7 meters per second. Can you tell me what the Bernoulli equation is?
Yeah, so you need to use like B1 and B2.
Yeah, very nice. Does everyone hear that?
It's either over 1.2 or 1.5. I can't remember what Benita says. I think she says 1.5.
I think she says 1.2. Yeah. So I have the same thing. When we're getting high area, particularly I guess when you're getting over 1.5 or 1.2, you've got to take that into consideration when you're trying to figure out a valve area. So instead of just 4V squared, which is the modified Bernoulli equation, you have to use the Bernoulli equation, because remember it's V1 squared minus V2 squared, but we completely ignore V1 squared as long as it's less than about 1, because then it's just 1 squared and then it's kind of small. But if you're getting above 1.5, then we're starting to get up into larger numbers and you've got to take it into consideration. So instead of doing 4V squared, you have to do 4(1) squared minus
4(1) squared minus
2 squared.
Yep. Yeah. Okay.
So I guess those, just a quick recap. So those are the ones that after you've known the bog standard stuff about an aortic stenosis, about the advantages and limitations of all the different ways of doing it, you've then got to know about low output states, pseudo-severe, paradoxical, low flow, aortic stenosis, high cardiac output states, and other states where you've got to consider using the full Bernoulli equation, not the modified one. Okay? And that's about everything I know about the aortic valve in 45 minutes. Any questions?
Sure that answer is going to be doing angiogram.
Do an angiogram, yeah. Do a stress test. Talk to cardiology. Palm it off. Pretend to be sick. Play possum. Yeah. All right, thanks, guys. See you next week.
Thank you very much.
Cheers.
Thanks, Sam. That was great.
Cheers.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.